In the United States, nearly 1 million new cases of sepsis occur each year, and is expected to increase by 9% every year.
Sepsis is involved in nearly 1 in 5 deaths in U.S. hospitals.
The cost and financial impact of severe sepsis and septic shock in the United States is enormous. It is the highest cost of care in inpatient in the United States, estimated at $20 billion a year.
Research has shown that early recognition and treatment of severe sepsis reduces morbidity and mortality and will save lives.
Sepsis is very complex, and in order to understand it, you need to know some of the definitions used. Infection is the presence of an organism in an enclosed space or a location where that organism is not normally found. Systemic inflammatory response syndrome, or SIRS, is the body's response to an insult. It can be due to infection, trauma, burns, or other insults resulting in tissue damage. SIRS is 2 or more of the following: hyperthermia or hypothermia, tachycardia, tachypnea. WBCs are either elevated or low, or 10% of your neutrophils are immature. Sepsis is SIRS with a suspected or known infection. And severe sepsis is sepsis with an acute organ dysfunction in at least one system of the body. Septic shock is defined as severe sepsis with hypotension despite adequate fluid resuscitation.
Well, by definition, sepsis is an infection plus systemic manifestations, such as the SIRS criteria. Now, sepsis is really a continuum. It begins with the early manifestations of SIRS plus infection, which is sepsis. If the patient isn't treated, then disease progresses. The patient experiences global tissue hypoperfusion, which then manifests itself by organ failure. Eventually, this progresses to hypotension and septic shock. Sepsis killed 258,000 people in the U.S. in 2009, 1 person every 2 minutes.
When severe sepsis and septic shock is recognized early and treated aggressively in an urgent fashion, that you markedly lower the mortality associated with this horrible disease. The quicker we can get these people diagnosed and appropriate treatment started, dramatic improvements in mortality have been achieved. That is exciting because it gives us something to do for this terribly devastating mortality as well as cost to our system.
100, 100,
100.
and the patient just doesn't look right.
Here at St. Cloud Hospital, we teach 100, 100, 100 as the screening tool for sepsis. So when you think 100, 100, 100, is your temperature greater than 100 or less than 96.8? Is your heart rate or pulse greater than 100? Is your systolic blood pressure less than 100, or it could have changed by more than 40 millimeters of mercury from baseline? And the patient just doesn't look right.
We see the patient coming through the front door into triage, and sometimes they just don't look right. Whether it's their color, it's their actions, they're really delayed, they look hot because they're feverish, or there's just something about it. And I think being in the medical field for a while, you kind of get a gut feeling that will tell you something's just not right.
I just don't feel good. I don't know what's wrong, but I don't feel good. The patient might say that, or the family will just say, you know, mom's just not acting like she was even earlier today.
They can come with very vague complaints. They may have very slight or altered changes in mental status. They could be just slightly irritable, restless, anxious. Use family members to kind of figure out what is the baseline for this patient. So once you've thought about sepsis and you've screened them positive using the screening tool, thinking in your mind 100, 100, 100, then you need to do a more formal kind of screening. Use that Sears criteria. Thinking again, temp, heart rate, blood pressure, using the 100, 100, 100. Think about some other things. Is their respiratory rate greater than 20? Is their oxygen saturation less than 90? If you have a white blood cell count, is it high or low? Is it less than 4 or more than 12? How about their serum lactate? Is it greater or equal to 2?
And the lactic is the key in identifying the early sepsis. Anything over 2.0 would be an indicator of sepsis. Anything over 4 is very concerning for severe sepsis.
They need to be triaged at a level 1 or a level 2. These are very sick patients. If the patient's already in the hospital and you've screened them and think they're possibly septic, you need to notify the physician. Use your SBAR communication. What's the situation? What's the background? What's my assessment that I'm seeing? And what's my recommendation?
This is Beth Klein from the ICU. I have Mr. Johnson here, and he's starting to deteriorate. The situation is he is screening positive for sepsis. The background is he does have pneumonia. The assessment, his blood pressure is 90/40, his heart rate is 120 sinus tach, his temperature is 101.3. I would like to proceed with the evaluation for severe sepsis, including blood cultures, UAUC, CBC with diff, and lactate.
Well, that sounds good, Beth. Why don't you go ahead and send off the lab work, including the blood culture and lactate, and I'll be up right away. Thanks. We need to start thinking about sepsis as one of the time-critical emergencies, just like trauma, acute MI, and stroke.
With trauma, there's a golden hour that you need to hurry up with an urgency, because the sooner you treat them thoroughly and comprehensively, the better the outcome, and severe sepsis is exactly the same way.
Surviving Sepsis Campaign 3-hour bundle consists of the 4 components: your lactate level, blood cultures before antibiotics, broad-spectrum antibiotics, and the 30 ml per kilo saline bolus.
If you think they're infected and they're sick enough to draw a blood culture, they need to have a serum lactic at the same time. The most frightening patient is a patient that is sicker than they look, and a serum lactic level may help you find that patient who is sicker than they look. On the front end, when you're looking, those first few minutes of when you're looking at a patient, trying to find out if this is someone who is going to have severe sepsis or septic shock, or someone with an infection that's under control, grabbing a serum lactic can make a difference as to whether you recognize that sick patient or not.
It is important that blood cultures and other cultures are drawn before antibiotics are started in order to identify the organism. The reason for that is that if we can identify the organism, we can narrow the spectrum of antibiotics and de-escalate the broad spectrum antibiotics and hopefully avoid increasing resistance to antibiotics in the future. Even though the 3-hour bundle recommends antibiotics within 3 hours from triage, the guideline actually recommends that antibiotics be started within 1 hour of recognition of severe sepsis. We know from good data that every hour delay in the administration of antibiotics in patients with septic shock leads to an increase in mortality by about 8%.
What's different about the paradigm for treating severe sepsis is the urgency, and antibiotics are one of the most important things you can do as fast as you can. Systems that have developed a very intentional approach to giving antibiotics in the emergency room in patients with severe sepsis and septic shock have done the best. That's one of the main key points to decreasing your mortality from sepsis in your community, is to get those antibiotics in as quickly as it can be. And that can be done at any hospital. That doesn't need to be done at a referring hospital.
Managing severe sepsis certainly is a team effort, and having the pharmacist involved has been extremely helpful. In fact, in our hospital, our pharmacist is part of our sepsis team. So when we page out a sepsis team, our pharmacist comes and helps not only with antibiotics, but is helpful in setting up some of the drips, such as the vasopressors and inotropes.
Well, as pharmacists, we understand the urgency of early antibiotic delivery to septic patients. We know that saves lives, that every hour that goes by, mortality goes up in these patients. And so we were engaged early in this process, and we made sure that we did things like have stat flags in the EMR and educated our staff about sepsis, and that we should be responding to septic patients the same way we would for a patient, say, with an MI. That's really critical.
The guideline recommends administering 30 cc's per kilogram of crystalloid or normal saline as rapidly as possible within 1 to 2 hours.
Resuscitation is one of the hallmarks of any form of shock. It doesn't matter what form of shock you have. And volume resuscitation is going to make a difference for salvaging organ function. And the question always comes up as to how fast should we give the fluid, and the answer is as fast as you can give it. Many people think that you need to have a central line in order to give fluid fast, and severe septic or septic shock is just like shock from trauma. What is needed is a shorter, large bore IV that can give fluid faster. If you have a pump so that you're able to push it in fast, that's great, but the faster you can get that fluid in, the better. Sepsis remains a silent problem in critical care and emergency medicine, accounting for more than 500,000 emergency department visits per year.
Seniors are 11 times more likely to be hospitalized with sepsis and are significantly more likely to die from sepsis.
And the mortality rate of sepsis is 40 to 60%.
More than 42,000 children develop severe sepsis each year. Approximately 4,400 of these children die, more than the number of children who die from pediatric cancers. The components of the seen sepsis transfer trigger tool include the following: a lactate greater than 4, or persistent hypotension or oliguria despite fluid resuscitation of 30 cc's per kilogram, or evidence of 2 or more organ dysfunctions, or progression of symptoms despite treatment. A lactate greater than 4 indicates global tissue hypoperfusion. And even if these patients do not have signs of shock such as hypotension, these patients are high risk and require aggressive resuscitation and require admission to an ICU with hemodynamic monitoring. If a severe sepsis patient does not respond to fluid resuscitation, they are going to require the use of vasopressors to maintain a mean arterial pressure of greater than 65. This will mean the patient will need a central line. The patient will also need an arterial line.
The outcome of severe sepsis and septic shock is so dependent upon an urgent recognition and an urgent resuscitation. The tool is designed as a way to help people recognize that this patient may have severe sepsis, as well as when they meet these criteria to give them permission to say, this is a patient that I need to move sooner rather than later, because I can do the best good for that.
If a patient presents to a hospital in a rural setting, or for example a critical access hospital that does not have the ICU resources, and if that patient is determined to have severe sepsis, then that hospital should begin to implement the 3-hour bundle as quickly as possible and make arrangements to transfer the patient to a hospital with ICU resources within 2 hours. Many times in patients who present with sepsis, they are on a downward course. And even with early intervention, many times these patients will continue to worsen before they improve.
To recap, Seeing Sepsis transfer trigger tool consists of 4 components. The lactate is greater than 4. They're unresponsive to fluid. They have 2 or more organ dysfunction and the progression of symptoms in spite of treatment.
Mortality from sepsis rises to 75 to 80% when 4 or more organs fail.
Sepsis is common and often deadly. It remains the primary cause of death from infection.
Every year, severe sepsis strikes about 750,000 Americans. It's been estimated that between 28 and 50% of these people will die, far more than the number of U.S. deaths from prostate cancer, breast cancer, and AIDS combined.
To recap the 4 main components of the 3-hour bundle, they are a serum lactate, appropriate blood cultures done early before antibiotics, early broad-spectrum antibiotics, and volume resuscitation at 30 milliliters per kilogram. The 6-hour bundle has 3 main components. First and foremost, making sure that you have a mean arterial pressure of 65 using vasopressors. The Surviving Sepsis Campaign guidelines are to start with norepinephrine, and if that's not effective, to use epinephrine, the goal being to maintain a mean arterial pressure of 65. Once again, it's really important to remind you that this is after they received the volume resuscitation of the 30 milliliters per kilogram. Vasopressors without volume resuscitation will get you in trouble in regards to ischemic gut, etc. The second component to the 6-hour bundle is usually accomplished in the ICU, and it involves hemodynamic resuscitation for patients who have persistent hypotension with their mean arterial pressure less than 65. It involves using fluid resuscitation as well as vasopressors to maintain a CVP of 8 or greater, as well as a mixed venous O2 saturation of greater than 70%. The third component to the 6-hour bundle is remeasurement of serum lactate. If your initial serum lactate was elevated, you want to recheck that during your 6-hour bundle to make sure that you're making progress in resuscitating the patient, making sure that there's not ongoing organ ischemia.
Stand by Patty, the doctor and the nurse. See there?
This is Mrs. Smith. She's a 50-year-old lady from a nearby hospital who was admitted with pneumonia. When she was seen in the emergency room, they drew a serum lactic level and it was elevated, so they transferred her up here. She received the 3-hour bundle in the ER, and when she came up here, we resuscitated her yesterday using the 6-hour bundle for severe sepsis. This morning, she looks quite a bit better. Her only complications that she had was a little bit of acute kidney injury upon admission that seems to have improved nicely. She remains on broad-spectrum antibiotics and seems to be doing much better. The plan is we'll probably keep her here for another day and then probably transfer out tomorrow. So if you want to warn the floors that she's coming, that would probably be appropriate. In English, what we said is you came in with pneumonia, you were really sick from that, it hurt your kidneys, and now you're better. You're getting better kind of all the way around. Do you have any questions for us? Pharmacist, do you have any questions or issues?
I don't think so. Her cultures are still negative, but it's only been not quite 48 hours.
All right, any questions? Otherwise, we're out of here.
I think we're good.
All right.
Now, whether or not you perform the 6-hour bundle in the emergency department or the ICU really depends upon your hospital and your resources available. Some hospitals, the 6-hour bundle may be performed in the emergency department with placement of a central line, art line, vasopressors, etc. Or in other cases, this may be done in the ICU. The important thing is that this is all done quickly. In some cases, the patient may need to be transferred to another hospital for the implementation of the 6-hour bundle.
The role of the nurse at the 6-hour bundle is to remain aggressive, to remain at the bedside, to monitor your patient frequently, update the doctor, and keep the family updated and involved.
So physicians who care for patients in the emergency department or in the hospital need to start seeing sepsis as one of the time-critical emergencies, just like trauma, stroke, and acute MI. Now, how many hospitals have protocols in place for the rapid evaluation and treatment of multi-trauma, acute MI, or stroke? But how many hospitals have protocols in place to treat and recognize severe sepsis? As physicians, we need to develop these protocols in our hospitals.
The most important thing that I would wish people to understand is that the care of the patient with severe sepsis or septic shock is a new paradigm. It's a different way of treating these patients than what we did 5 or 10 years ago. And what's different about it is the word urgency. If I were to leave you with a word, I would like to leave you with urgency. Urgency in the diagnosis, urgency in the broad-spectrum antibiotics, and urgency in fluid resuscitation. Early and broad-spectrum antibiotics is one of the key points of improving the care of the patient with severe sepsis and septic shock. Every institution has their different plan and strategy for how they use antibiotics, but common pairings for broad-spectrum coverage include meropenem and vancomycin, or piperacillin and tazobactam. These are antibiotics that are used in the immunocompetent host, and if a patient is suspected of having a community-acquired pneumonia as a source of their severe sepsis, then an antimicrobial to cover atypicals would be appropriate.
Even though we begin treatment with broad-spectrum antibiotics, we are also concerned about antibiotic stewardship. And that's why we have included in our protocol that the antibiotics be reviewed in 72 hours and de-escalated based on the culture results that are obtained at that time.
You're okay to start a broad-spectrum antibiotic, and anybody who's ever had a patient dying in front of them wants to give them every chance that they can to live, including every antibiotic coverage or a coverage of every bug at that time. The trick or the important point is in regards to antibiotic stewardship is to de-escalate when you have a chance.
I think sometimes people withhold fluids because they're worried about fluid overload. In this case, however, it's essential that these patients get these fluids early on, and many times patients will require several liters of fluids within the first few hours. Of course, we watch for evidence of fluid overload, and that's one of the reasons we will insert in a CVP line to look at the CVP. We also use ultrasound to assess the IVC diameters to assess for fluid responsiveness. But certainly fluid overload is something that we watch for, but it's not a reason to withhold fluids.
We save people's lives because of the intentional effort directed at this problem, and that is making the corner of the world that you live in a better place.